Hello, everyone, and welcome to today's webinar, Troublesome Physicians and Providers, Challenges, Success Stories, and Lessons Learned. Thank you for joining us. I am Lisa Allen, President of the Michigan Association of Medical Staff Services, and I will be the moderator for today's program. Today's webinar is being sponsored by the Michigan Association of Medical Staff Services and hosted by the Hardenbergh Group and MDReview, a Hardenbergh company. Before we begin today's program, I'd like to share a few housekeeping details. All attendees' microphones have been muted for this presentation. To ask a question, click on the Q&A icon located on the navigation bar at the bottom of your screen and type in your question. You'll also see a chat icon, which can be used to submit comments and/or questions during the presentation. As time permits, at the end of the program, I will read the submitted questions and ask our presenters to respond. Your NAMSS-approved CE certificate will be emailed to you within 48 hours directly from Hardenbergh in your "Thank you for attending" follow-up email. Also included in the email will be slides from today's presentation and a link to a short survey. We hope you will take a few minutes to share your feedback. Now it is my pleasure to introduce today's presenters, Dr. Don Lefkowits and Dr. Brock Bordelon from MDReview. Sorry about that. Dr. Lefkowits is the Medical Executive Director of MDReview. He received his undergraduate degree, medical degree, and completed his residency in internal medicine at Dartmouth College in Hanover, New Hampshire. He began his career in emergency medicine in 1980 and has practiced at Rose Medical Center since 1984. During his tenure at Rose, Dr. Lefkowits served as a member of the Hospital Board of Trustees, President of the Medical Staff, Chair of the Credentials Committee, and Chair of the Peer Review Committee. He supported hospital and medical staff functions by chairing fair hearings, providing crisis management and press interactions, and developing and nurturing physician leadership programs. As medical director of the emergency department, Dr. Lefkowits put into place state-of-the-art cardiac, stroke, and trauma alert programs and helped the Rose ED lead the way in programs to enhance ED throughput and patient safety and satisfaction metrics. Dr. Lefkowits is board certified in emergency medicine and internal medicine and currently serves on the Colorado Medical Board. Dr. Bordelon is the medical director of MDReview. He attended the University of Texas Southwestern Medical School, followed by a general surgery residency at the University of Utah School of Medicine. Dr. Bordelon is certified by the American Board of Surgery and is a fellow of the American College of Surgeons, the Society of Surgery of the Alimentary Tract, and the Society of American Gastrointestinal Endoscopy Surgeons, among other regional and national professional societies. He has practiced general and minimally invasive surgery in Colorado Springs since 1984 and has served as the chief of surgery, a member of the Medical Executive Committee and the Citizenship Committee, among several other hospital medical staff functions. Dr. Bordelon was a member of the Colorado Medical Board for 4 years and served as the chair of one of the board's inquiry panels during that time. Now, I'd like to welcome Dr. Lefkowits.
Thanks so much, Lisa, and thank you everybody for joining us. We're looking forward to diving into the topic, which generated quite a bit of interest, but I'm sure we're all happy to wake up this morning and relishing finding a day without any political ads today. So it's a good way to start the day, regardless of what your political persuasion might be. But what we're going to talk to you about today is troublesome physicians. It generated quite a bit of interest, not surprisingly. I think it's the sort of thing where we're gonna define it for you, but it's the sort of thing that you know it when you see it. We talk about the problem child, using the term child euphemistically. It's the disruptive physician. It's the non-collegial physician. Sometimes the rude physician doesn't really understand interpersonal relationships very well. Or as I began to use the term when I became more senior in my leadership experience, just don't be a jerk, okay? But I think you all know what we're talking about. So in the course of the hour that we're going to be with you, we're going to talk about what is it and why does it matter? Why does it happen? We're not psychologists, but we can give you a little bit of insight as to why physicians and providers can be problematic. What can you do about it? And we'll end with why is it important that medical services professionals actually understand and care about it, because they do play a very important role. Before I turn over the first set of slides to Dr. Bordelon, I just want to set the stage a little bit by giving you a little more background about the two of us. As Lisa mentioned, I started my clinical practice as an emergency physician in 1980 in Denver. I was fresh out of residency, and I sort of somewhat accidentally found myself later on in my career as in a variety of medical staff leadership roles. About a decade after I started, Dr. Bordelon started and sort of followed a pretty similar course, starting mostly just as a clinician and then working his way into some medical staff leadership roles. And the reason I bring that up is that I just want to remind some of you more senior medical services professionals that back in the 80s and 90s, when I was first practicing, there were plenty of troublesome, difficult physicians, but we were really all encouraged to look the other way. I actually participated in discussions with our CEO, and it was back when medical staff leadership roles weren't necessarily quite as well defined. Certainly medical staff leaders weren't as well trained as they are today. I had a CEO who thought he had his AMD degree, we used to call that an almost doctor degree, and fancied himself as the go-between and the decider of who should practice, who shouldn't, and what constituted unacceptable behavior. And I actually recall the CEO talking to nursing staff, other physicians, other leadership teams, and using phrases like, well, why don't you try to anticipate his needs better? And I'm using the male term, because that's pretty much who troublesome physicians were back then. Terms like, well, he's such a good surgeon, let's just put up with his bad behavior. Or he's the one who's paying the bills. Or even worse, why do you just make him mad all the time? And I actually heard him say when there was a complaint about throwing things in the OR, well, you just need to duck. Obviously, all entirely inappropriate and would not be acceptable by today's standards. But that's sort of where we were coming from. And now what we're going to talk about is 2022. How do we identify troublesome physicians? What's at the heart of what may be causing their problems? Why does it matter? And more importantly, what do we do about it? And how can medical services professionals help your medical staff leaders deal with these pretty challenging issues? So with that, Sharon, if we can move to the first slide, and I'll turn it over to Dr. Bordelon.
Great, thanks a bunch, Don. I think really the big question here is, what are we really defining? What kind of a physician are we talking about? Troublesome basically means somebody that's causing difficulty or annoyance. But in the professional world, there's a whole raft of different behaviors that can be troublesome and disruptive. Yelling, public criticism of colleagues, physical aggression, whether or not you're actually touching someone or not, that idea that you might be being acted upon, some passive aggressive behaviors, that hostile avoidance or not speaking to individuals that are caring for your patients, intentional unresponsiveness. I'm sure that most of you have had complaints about physicians not responding to pages, being condescending, impatience, extreme sarcasm, implied threats, and even intentional miscommunication. So if you go to the next slide, Sharon. Disruptive is the same thing, but it's actually defined by the American Medical Association as any abusive conduct, including sexual or other forms of harassment, or forms of verbal or nonverbal conduct that harms or intimidates others to the extent that quality of care or patient safety could be compromised. Next slide. And I'd like to emphasize that quality care and patient safety are really what we're all about. And as Don was describing in the past, we would kind of put up with some bad behaviors because making that connection between poor behavior and bad patient outcomes really wasn't well linked. There's no question today that every time we have a physician that's behaving poorly, we're putting patients at risk. If you go to the next one. So, why does it matter? Really, in the long run, this has negative impacts on patient safety. I think, Don, you were going to pick up and kind of run with this one as well.
Yeah, so negative impacts, and Brock referred to some of these things, but first and foremost is patient safety. Positive outcomes, that's what we all strive for, safe patient conditions, and disruptive behavior certainly interferes with open communication and an effective team approach to patient care. It affects employee morale, employee retention, physician collegiality. It also can affect the institution's reputation, team effectiveness, the esprit de corps. We have there listed patient satisfaction, but I think there's another thing that's important to talk about, and that is provider satisfaction. We get up and go to work every day to take care of patients. It's a challenging profession. It's more challenging now than ever. And provider satisfaction is important. And part of provider satisfaction is professional self-worth. You want to be part of a high-functioning team. You want to have pride in the work that you do. And when there's a disruptive individual or individuals within the context of that team, it's much harder to feel good about your workday and end up your workday, feeling like what I did was valuable and contributed to positive outcomes. Certainly, medical errors, medical legal risks, and it can even affect hospital finances. When somebody is feeling like they're either unappreciated, being abused, attacked, or under duress because of somebody else's behavior, they're going to be less likely to pay attention to those critical things that help you avoid medical errors. Next slide there, Sharon, please. Here's another topic or another issue regarding this, and that is that it's very hard for people to speak out about the problem. And as I mentioned in the history of all this, we used to just look the other way all the time. But what we know now is that if it's not addressed, it deals a huge blow to the culture of safety, makes creation of a culture of psychological safety nearly impossible to pull off. It undermines the trust, the sense of teamwork. One of the things that I enjoyed most about my 40 years in the emergency department was the team. We had techs, we had nurses, we had a secretary, we had radiology techs, we had lab techs, we had EKG techs, we had PAs, we had docs. That team approach could be severely, and sometimes was severely, adversely affected if one of those team members was non-collegial, non-supportive, disruptive, or behaved in a way that undermined that sense of trust and teamwork. Next slide, Sharon. Thank you. There are also examples of physicians in whom there's been some success in dealing with behavioral issues, and they can actually be a resource for other troubled individuals who can turn to somebody who can say, I used to be that way. I understand what's been eating at you or why you're feeling like you need to be disruptive. And let me tell you the course of action that got me on the right path. It also sets an example not only for the remainder of the medical staff, but when you do identify and intervene, it also sets an example for the entire hospital staff that medical staff leadership takes it seriously, takes trust and teamwork seriously, and takes steps to ensure that everybody from the chair of the department all the way down to environmental services, and everybody in between is rowing the boat in the same direction. Next slide.
So, there are some root causes that have been evaluated for professional misconduct, and it's not just in medicine. And there's several of them that are relatively consistent: substance abuse and underlying psychological disorders, the sense of narcissism or perfectionism, home life issues. Clearly are an issue in all of our lives, and can really spill over into the workplace. Some folks have really difficulty with controlling their anger, especially under stressful situations. And young folks, oftentimes in stressful positions, will tend to lash out when they have feelings of inadequacy or insecurity. That young surgeon who sometimes gets into a position in the operating room where he's not 100% sure where to turn next, oftentimes will turn against the staff that's trying to help him because of his own insecurity. But really the two biggest ones I think that are important to highlight as far as what we need to understand is that bad behavior oftentimes gets desired results. Don described a minute ago the physicians that were acting poorly oftentimes were given a pass by the administration because nobody wants to listen to them anymore. So that bad behavior gets reinforced and rewarded. If you hit that next slide. But the other is that clinical and administrative inertia also occurs. We don't really address things adequately. We're not necessarily paying as much attention to it. Nobody wants to deal with the problem. And over time, that leads to normalized deviance. Sharon, if you'd hit that next slide. So normalized deviance is basically the process by which bad behavior gets reinforced as being normal, so nobody speaks up. Classic example outside of medicine is the Costa Concordia disaster. The captain routinely disobeyed routine orders from the company not to stray too close to the Italian coast. Next thing you know, nobody spoke up. They run aground and people lost their lives. The exact same thing occurs in medicine. When we allow physicians to behave poorly, it simply gives them license to continue to do so and put our patients and our staff at risk. Next slide.
Yeah, so, and it's a really important point, Brock, and we'll talk about this later on, but what it emphasizes is the importance of early identification and early intervention. And we'll talk about methods for intervening and starting collegially and then moving up the pyramid to more significant interventions. But it is such an easy thing to look the other way. And yet the earlier you're able to intervene in a provider who is exhibiting signs of some disruptive non-collegial behavior, usually the easier it is to correct it, and the less likely it is to then go on to cause more serious underlying problems within the system. So let's talk a little bit about Joint Commission and why it's important. I know many of you serve in the role as survey readiness for your facility every 3 years. I think Joint Commission still does every 3 years. Maybe it's every 2, but and now there are equivalents to the Joint Commission who are doing similar things, but they all have a focus on the importance of disruptive behavior and disruptive physicians. There are two elements under the Joint Commission. The first being the hospital organization must have a code of conduct that defines acceptable and disruptive and inappropriate behaviors. I was doing a presentation at NAMSS not too long ago, and I actually surveyed the audience. It's a little easier to survey the audience when you're there in person. I was very surprised to see that only about 50% of the medical service professionals who were there identified the fact that they had a code of conduct and that they knew what it was, that physicians knew what it was. I think having a well thought out, specific and discrete code of conduct, and not just having it, but our recommendation is that at every credentialing and then recredentialing every 2 years, that a copy of that code of conduct is signed by the provider during their application process, and that a copy of that signed code of conduct gets sent back to the privileged provider so that they have a copy of the code of conduct that they know that they signed and have agreed to live by. And then the second is that medical staff leadership must create and implement a process for managing disruptive and inappropriate behaviors. As is often the case with the Joint Commission, they sometimes focus less on the specifics of the process and more on the fact that you have a process and that you live by the process, enforce the process, and document that the process is working successfully, or if it's not, feedback loops that allow you to revise the process so that it is, that it's successful. Next slide. I'll go back to you, Brock.
Okay, so one of the things that's really important in that last slide is that the Joint Commission isn't specific about what they're expecting, but when it says medical leaders, I always view that as pointing a finger directly at all of us. That's the physicians, it's the physician leadership, it's the hospital leadership, and medical leaders is somewhat of a misleading term, but it's our responsibility to build these processes and enforce them. So really, what is a code of conduct? Just to give you a quick example of something that I've run across in the past couple of months, was at a facility that was very well meaning, and they had a physician who'd been disruptive for multiple years. And there was significant inconsistency in how their code of conduct was applied, changes in it over time that really weren't communicated. And on top of that, a kind of a minimalist approach to documentation of the multiple interventions that occurred over time. So they've reached the point of institutional exhaustion with this physician with ongoing behaviors, but because they haven't followed their own policies to the letter or documenting that they had done so, they're in a position where it's very difficult to deal in a meaningful way with this physician. So starting with the framework of the code of conduct, we've kind of run through the framework that the Joint Commission has kind of run through it. And Don just said the code of conduct needs to be very clear, very specific, and very up to date. So we go to the next slide.
So no free passes. Actually, just go. Can you, Sharon? Can you just go to the next slide? Yeah. So there are some important things here. Implement and development of policies and procedures that address specific things. There should be zero tolerance for intimidating or disruptive behavior. Incorporate this into your bylaws, into your code of conduct, administrative policies, and also employment agreements. We have a number of facilities who have employed agreements with physicians, and there are some differences there between privileged physicians in a democratic independent medical staff and employed physicians, mostly related to HR issues, but still the basics need to apply across the board. Medical staff policies should be complementary and supportive of the policies for non-physician staffs. Now, here's a very important part of a disruptive behavior policy, and that's non-retaliation clauses should be included in all policies that address disruptive behaviors. One of the things that makes it very difficult and challenging for staff, whether it's colleagues, other physicians, physician assistants, nurse practitioners, nurses, or anybody else that may be witnessing disruptive behavior, is the reluctance to want to say anything about it for fear of retaliation. And it needs to be stated very clearly right from the start, and especially when you approach a provider to begin talking about their disruptive behavior, is that it's understood that it doesn't matter who filed the complaint, and it certainly is never appropriate to think, I think I know who said this about me, and then do anything in the way of retaliation. It even makes it undermines the entire situation even to a greater degree. So if you have a good non-retaliation clause, it makes it easier to report the behavior in the first place. Response to patients and families who witness such behaviors. It certainly disruptive behavior can undermine the trust that patients and family members have in the facility. We've seen that in a number of circumstances. And then, you need to decide how and when to begin disciplinary actions. And it can go anything from suspension to termination, loss of clinical privileges. And part of the approach you need to keep in mind is that there may be some situations where you are required to report to your professional licensure bodies. Both Brock and I served on the Colorado Medical Board. I still have about 6 months left in my term. But we do hear and get reports of disruptive behavior when it rises to a certain level. One of the things to keep in mind, there's another issue that's not listed here that I'm just thinking of, is an opportunity for a leave of absence. If there's been an identified medical issue, psychiatric issue, substance issue, Perhaps none of these steps to suspension termination are appropriate, but it's entirely appropriate for a provider to take a medical leave of absence just to remove themselves from clinical care until those potential issues can be addressed and resolved. The other thing to keep in mind is that these steps to resolve disruptive behavior can be used as a leverage tool to encourage. We're going to talk about why physicians tend not to be very self-reflective and understanding of what their issues are. But these tools, the potential for disciplinary action can be used as a leverage tool to get cooperation from the physician under review right from the start, and sometimes makes the entire process a little bit easier. Develop organizational processes for addressing intimidating and disruptive behavior. Solicit and integrate meaningful input from all team members, medical staff, nursing administration, other employees. Make sure that the meat of your disruptive behavior policy has taken into account all different perspectives so that you're not leaving anything out. Everybody is important in the process of identifying what disruptive behavior is. And more importantly, what makes you feel good about being at work? What makes you feel like a valued team member? Because policies should include positive things. A code of conduct should include, here's what we encourage: collegiality, teamwork, praise, support of other team members, from top to bottom. Next slide there, Sharon. Thank you. Provide skill-based training and coaching for all leaders and managers, relationship building, collaborative practices, feedback skills, conflict resolution. This is the difficult conversation. I love Chevy Chase. That's a pretty young Chevy Chase there. The role of a medical staff leader does not necessarily come with inherent skills at having those difficult conversations. So your medical staff leadership maybe needs some help in how to approach those difficult conversations. And there are a lot of courses that are available, but those difficult conversations are not don't necessarily come easily, and it's important to provide your medical staff leaders with some of that support. Back to you, Brock.
Great. So, we need to be able to make sure that we implement a system for assessing staff perceptions of disruptive behavior. Kind of like making a safety net, an evaluation system that needs to be in place that to identify those behaviors that create barriers to good patient care and good teamwork. Basically, the emphasis again is on patient harm. You implement this reporting and surveillance system to detect those unprofessional behaviors and monitor them with regular surveys and focus groups, peer evaluations, and team member evaluations, again with specific strategies designed to learn whether disruptive or intimidating behaviors exist or recur. Catching poor behavior in this environment can be a little bit like trying to spot a whale at sea in bad weather. We all need to take some responsibility for keeping our eyes open, with the willingness to jump up and shout, there's Moby Dick, even though sometimes we may not be correct. And we know that this isn't a fishing expedition, but really a safety watch on the lighthouse. We need to establish tiered, non-confrontational interventional strategies, this kind of pyramid process of starting with relatively low stress coffee type conversations. Develop some detailed action plans where required, and if the behavior pattern persists, some progressive disciplinary options. Building some trust and ensuring accountability during those early phases by acting early and taking relatively straightforward and strong and consistent action makes an enormous difference. We always want to attempt rehabilitation, but with an eye to protect patient safety. As things progress with physicians that simply are uncoachable at a local level, sometimes we need to bring in outside mediators and coaches where needed. Again, the vast majority of these folks will respond to that simple coffee conversation. That's a peer pressure type of an issue, and that's where you can really leverage your physician leaders to lead those conversations and hold those other guns at bay until you really need to pull them out. All these interventions need to be undertaken with a commitment to the health and well-being of the staff, and that includes the physician. It is not unheard of to identify previously undiagnosed mental illness, and treatment of that can significantly impact somebody's career. I mean, this can be a little bit like, if you go to the next slide, this can be a little bit like the tip of the iceberg. So we need to make sure that we provide adequate resources for behavior that's associated with either physical or mental health issues. If you go on to the next one. And I think it's on to you, Don.
Thank you. So encourage interprofessional dialogue, protective mechanism to address ongoing conflicts, improved collaboration, improved communication. These are all things that are of critical importance. I just thought of a story, and this is the first time Brock and I have presented together, but one of the things we talked about just a couple of slides ago was the issue of feedback, continuous feedback, and maybe even part of the OPPE process. But I recall when I had been chairman of the emergency department. It's about a 45,000 visit ER. We had 15 docs, 6 PAs, 70 nurses, and we did a 360 review of everybody, and including me as in the role of chairman. And one of my personal traits that doesn't always go over so well is when I'm in difficult situations, I tend to use humor, sometimes inappropriately. And one of the feedbacks I got, it was anonymous, was just a simple one sentence that said, not everything's a joke. And I wasn't exactly sure what they were talking about. And then it dawned on me that sometimes when we're in a difficult situation, I maybe make inappropriate use of humor, or and in the ER, obviously we use black humor pretty often just to get through the day. But anyway, it just triggered that thought. But the ability to continuously survey staff about how people are doing, getting that feedback, sometimes including it even in OPPE data, so that it's another step towards early identification of when somebody may be being perceived as disruptive, even if there hasn't been a specific event or incident that triggered that report. So next slide, Sharon. So you want to make sure you document all attempts to address intimidating and disruptive behavior. If, as they say, if it isn't documented, it doesn't happen. One of the things that we've run into when we're asked to maybe do a site visit when there's a problematic physician, is there is often very little in the way of detail about what the initial events were, what the behavior was, what other people reported about the behavior, and certainly very little detail about what steps have been taken to try to address the intimidating and disruptive behavior.
So, what are some of the barriers that we run into in managing these folks? I mean, this can be akin to a prize fight. You're in for the long haul, and there can be lulls in the action, but oftentimes there are multiple barriers that get thrown up into how we're going to actually manage these folks. So, probably one of the first that comes up, particularly on the physician side, is, are these complaints real or not? So, making a differentiation between spurious and serious complaints takes time and effort. And it takes time and effort on the part of the medical staff professionals as well as the medical staff leadership. There's frequent turnover of medical staff leadership, and that just sort of leads to a loss of that continuity of understanding of what's been going on with an individual physician's behavior. And the same thing occurs in the medical staff. So there's a loss of institutional knowledge. You have to remember that this is a long haul process, and that's really where the critical nature of documentation with specificity provides protection for the institution in the long haul, to make sure that we have a new physician leader and perhaps new medical staff office personnel. They've got a file, and Dr. Bordelon's been acting poorly for 25 years, and this is just the most recent event. But if there's very little detail in that file, nobody really is going to understand that it fits into a pattern of behavior that needs to be addressed, probably sometimes at that point in a serious manner. The next big barrier is a fear of reprisal, like Don was just saying. It is not uncommon to have hospital staff say, look, if I talk about Dr. X, because of his behavior, all he's going to do is treat me poorly the next time he sees me, ignore me, make rude comments, talk about me behind my back. It's just not worth it. And that's where the whole idea of high reliability comes into play, with making sure that everybody is on the same page about feeling comfortable with bringing up issues that affect patient care. Obviously, there's hospital and physician politics as well as competition that play a big role into this. But the last big point is that most physician leaders have never been trained and do not feel comfortable having difficult conversations with their peers. And that's a huge, huge issue. So if you go to the next slide.
Yeah. So, and I love this picture, but back to difficult conversations. I suspect some of you have heard me tell this story before, but so I'll make it briefer than I usually do. But I was only about 6 months into my first term as chair of the Department of Emergency Medicine. We had a difficult, a challenging situation with a very talented provider who had this ability to get triggered by a certain type of patient and end up making the patient cry. And we went to great lengths to try to get this physician the help they needed to learn how to have better, more positive interactions with patients. And it was only a very small subset of her patients that triggered this response. But long story short, it was unsuccessful, and it turned out we were going to have to let the physician go. So this was the first time in my entire life that I was going to have to terminate somebody. And I was meeting with this physician 8 o'clock the next morning, and I spent the entire night tossing and turning. I couldn't get any sleep. And the little that I did sleep, I had this very vivid dream that the physician was drowning in a lake, and I was right on the shore with my arms crossed saying, "I'm sorry, I can't help you. You're going to drown. I'm sorry, I can't help you." Obviously not a very hard dream to interpret, but it shows you how challenging it is for physicians who have no training in difficult conversations, are trained to be clinicians, not necessarily managers, bosses, or have a conversation with somebody who needs to be terminated. It turned out that the physician came in the next morning and pretty much did my job for me, apologized, said, "I know you're going to let me go." And anyway, it worked out fine. But this is the hurdle that we face. And at the end, I'm going to talk about why it's so important for medical services professionals to support your medical staff leadership in supporting them and having those difficult conversations. But another quick story, I know we're sort of running a little bit late on time. So this picture reminds me, when I was president of the medical staff, I had a very small office in the medical staff office, which was a much bigger office. And that office let me see the welcome desk where Sarah, is sort of the secretary and administrative assistant who was at the desk welcoming people, sat. And I saw with some regularity, physicians come in with exactly this face, getting in Sarah's face because their ID card didn't work for the doctor's lounge for their free lunch, or the parking pass didn't work to get into the parking garage. Incredibly trivial issues, but triggering this outburst of behavior as if it was Sarah's fault or that Sarah could fix it immediately. So why is this important? It's that disrupt, and I often thought, I'll show you how old I was. This was actually before cell phones. I wish that now, as I think back, I could have actually taken pictures of what they looked like and showed it to them to say, this is how you appear. The problem is that disruptive physicians often lack the insight to recognize how their behavior is being perceived and how inappropriate it is. They often don't collaborate in solving what the issues are. And many of the traits, Brock's going to talk about this in a little more detail in a second, but many of the traits that actually led to them being successful in becoming a physician are liabilities when it comes to collegial behavior.
If you take that next slide, Sharon. So, I mean, when you think about physicians, you don't get into medical school without having, intelligence and the ability to be self-reliant, independent, being able to think about things objectively and analytically. You have to have a sense of urgency, and depending upon a physician's particular practice, that sense of urgency can be extremely important. And obviously, you have to be able to influence people. If you go to that next slide, the challenge is that when a physician is disruptive, those attributes can become significant liabilities. These folks can be very manipulative. They use their outsized influence really to bully other people into silence. Because they're objective and analytical, there contains very frequently contain either a small or even a large amount of truth in them, but they don't act in a terribly pleasant manner in pointing those things out to anybody who will listen. And they become basically somebody whose poor behavior gets reinforced because they're able to cow everybody into submission over time. And their personalities become toxic and creates a very toxic environment for our staff members. Next slide. So let's talk a little bit about the elephant in the room. There's some other really important barriers that we all have to be aware of and find a way to manage ourselves around to dealing with these folks. Reimbursements going down across the board. Costs are rising across the board. Revenue generation is crucial. There are powerful incentives for institutional inaction. If there's a spine surgeon who's bringing a ton of money into your facility who acts like a jerk most of the time, it's very difficult to get action on the part of the C-suite to really address that in a forceful manner. Hospital leaders and medical staff professionals, though, everybody needs to recognize, though, that there are risks to inaction. And those risks involve patient care, staff turnover, and all the other things that we listed at the beginning of the talk. It's absolutely crucial to remove that financial component from this discussion. And quite frankly, unfortunately, this is the discussion that I've had to have 3 times in the past 6 months at my own institution about what are we going to do to address these behaviors for these very productive physicians. And because they were very productive, they weren't addressed early on. And so we're really trying to play catch up. If we're able to address those right up front, even with a very productive physician, you can usually get them back on the right track. So
let's talk a little bit about overcoming obstacles. And Sharon, you can go right on to the next slide. Oh, you want to address this pyramid?
No, that's perfectly fine. Go ahead.
Yeah.
Go ahead.
Yeah. No, go ahead. You do it.
Okay. So really, the whole idea is that this is the Vanderbilt policy. I think many people have seen kind of that tiered process. In some respects, we kind of have to think about the effort involved is a little bit inverted. So those early unprofessional incidents, most of those are treated quite easily with a coffee cup conversation. The vast majority of physicians don't require any additional ongoing evaluation. When there's an apparent pattern, we kind of move up the pyramid scheme to some awareness intervention, some guided intervention by authority figures, and then disciplinary intervention. And that's sort of the framework that most institutions use to try to make sure that we address things in a consistent fashion. And that whole idea of actually putting numbers or letters onto them allows subsequent folks who are looking at these documents to know, okay, this was a level 1, this was a level 3, or an A or a C, so that there's a consistent approach to what we're dealing with. You hit that next slide. And absolutely document.
Yeah. So, the coffee cup conversation over the years, I found myself in a number of those. And one of the things I learned is that Brock's right. For many, or maybe even most, that early coffee cup conversation, the collegial approach, can generate the change that you're looking for without having to go further up the more challenging parts of that pyramid. And what I learned was early on in that coffee cup conversation, I got a pretty good sense of how successful we were going to be simply by the initial response of the provider, the physician or PA that I was speaking with. And it was interesting because more often than not, the response that I would get, and it was what I was looking for, was almost a sudden look of dismay, and then a response of, I had no idea I was being perceived that way. And that usually was opening the door to listening, taking in the feedback, and asking, how can I do better? And obviously, that's the ideal circumstance where you have somebody who has insight and is interested in improving. Sometimes it was the exact opposite. How dare you? Who do you think you are? Who told you that? And that almost immediately triggered in me, first of all, the desire to want to leave the conversation right away, but more importantly, recognizing this was going to be a challenge. That entire pyramid was likely going to be needed to be pulled into play. And those were the ones that where I felt like I really earned my keep. So what are some of the in-house toolboxes to being successful in overcoming the obstacles to disruptive behavior? Cultivate a team of physician leaders to support each other. This was something that I started to rely on when I was president of the medical staff. I had department chairs, and I got to be very close with the department chairs. We met monthly. It became, the power of the team, the support of other similar providers who were in similar positions to help support with those difficult conversations. The other value of a team of peers is that sometimes when you approach a provider as a team of peers, it's viewed as less judgmental. It creates a safe space for that struggling physician to open up a little bit. Perhaps they are under some stresses that we're not aware of. And it also helps maintain the dignity. The more collegial, dignified approach to addressing somebody with disruptive behavior, the more likely you are to be able to reach them and be a little bit more successful. Chief of Staff boot camp programs, as we talked about, sometimes your medical staff leadership is going to need some support, some help, and some training in how to approach these things. Some peer coaching. We have our Colorado-based largest malpractice insurer, Copic, has a physician who's a peer coach. And when they have physicians who've been identified as struggling, they do hands-on, one-on-one training in handling difficult patients, in doing better with collegial behavior with colleagues. And then the last thing to think about is a citizenship or professional committee. Perhaps it's better to take out disruptive behavior from the entire clinical peer review process. It can help prevent leaving all behavior issues up to the CMO. Should not just be a CMO situation. Department chair should be helpful in interacting with disruptive behavior. It ensures the documentation of interventions, and it creates awareness amongst the entire medical staff. Let's go on to that next slide. I'll go back to you, Brock. We're coming to the end, and we will have a few minutes for questions.
Okay, so really the whole idea behind that in-house toolbox is to build an appropriately robust infrastructure. And as somebody who has spent a tremendous amount of time doing peer coaching and being on the citizenship committee, I can tell you that that is probably the most crucial piece to this, to making it flow with consistency and fairness. And the idea is we want to do things in a manner that's so consistent that we're not asking that question, well, gee, I can't remember, what did we do the last time? We want to be focusing on consistency with how we approach these folks. The next slide. So what's the outside resources? What other options are available once you've exhausted what's available to you on the inside? Well, pretty much every state has a physician health program, and that's really important. It's usually paid for by physician licensure fees. There are specific physician education programs. The one that Don and I are the most familiar with, because it's located here in Denver, is the CPEP, or Center for Personalized Education for Professionals. Lots of folks are sent there or even seek it out on their own from across the country. And those education programs run the gamut from behavior to evaluation of performance and those sorts of things. And then sometimes you need to pull out your relief pitcher and send somebody for an intensive, week-long or longer evaluation with psychiatric and psychologic professionals. And the one that's probably the most well-known in the country is Acumen in Kansas. Next slide.
So
what about supporting your medical staff? Go ahead, Don.
Yeah, so why is it important for medical services professionals to know? We spent almost an hour talking to you about disruptive physicians, and it really comes back to the fact that many medical staff leaders are new to the role, don't really understand some of the dynamics, maybe don't have the institutional memory. It's a little different if you're in a facility with a full-time CMO who's experienced, trained, has a master's in medical management or an MBA. They may be more adept at some of these things, but I think most, or at least many of you, deal with continuous turnover in your medical staff leadership. So Sharon, can you just go on to that, the next slide? Yeah, so how do you support, why is it important for medical services professionals to understand what we've been talking about and serve as in the role of supporting medical staff leaders? I can't tell you the number of times I remember walking into my medical services director, Beth, and plopping down in a chair and putting my head in my hands saying, I don't really know where to turn. I know it's a problem, not really sure what to do about it. And there would be listening, there would be polite, well, have you thought about this? Maybe. The fact that usually medical staff professionals have been there for a while, they have better institutional memory, and they've seen this before, perhaps in their years of employment, and have a sense of how to go about it. And it's that dynamic that can help support your medical staff leadership in addressing issues. The other thing that I do want to talk about, we talked there about availability of HR and legal teams, and certainly when you're facing difficult challenges with behavior with physicians, involving hospital legal team is important. But you as a medical services professional are also that link between the C-suite and the hospital medical staff leadership. And oftentimes there's a challenging dynamic there revolving around a specific physician, especially if they're contributing to the bottom line of the hospital. And being caught in that role or being in that role, it comes with the territory. You can often help balance the scales towards the medical staff leadership, knowing that when all is said and done, they really have to do the right thing. And that's what's most important. So keep on task, moral support and encouragement for your medical staff leadership. There were times, I know this sounds silly, where I was resistant to doing what I knew I needed to do. And all I needed to hear was, Don, you're the adult in the room. You can do this. Now go do it. I know it may sound silly, but that's really what I needed to hear. And I'd go off and accomplish what needed to be accomplished. So I'll turn it back to you, Brock, and we'll close and then have a little time for questions.
Okay, so closing loop is just crucial. I mean, physicians are hardwired to find answers and solve problems. And so when troublesome problems like this are floating out there, kind of in the ether, with leaving no absolute clear-cut resolution, the medical staff leadership who is there and wants to help you kind of turns apathetic. So we have to be sure that we keep close communication with those physician leaders about those specific issues and say, okay, now we've put this one to bed. So loop closure is really crucial. So if we go to the next slide. So I'd just like to finish up with talking about a bit of a success and a bit of a failure and some lessons that I learned with this one particular physician. This is a young guy who, by the time that everything wrapped up, was 42 years old. He was a great surgeon. He was a wonderful clinician. His patients loved him. He had excellent results, but he had significantly poor behavior. His operating room behavior in particular was just atrocious. He was belittling of the staff, angry, progressing to the point where staff members refused to work with him, and we had staff turnover and loss. When the initial complaints began, we did the usual coffee talk. Things went well. The CMO actually sat down and spoke with the physician with the first complaint. And that physician then, of course, had his litany of issues that he was concerned about. And so they were able to hash that out. That went okay for a couple of months, followed by another complaint with a much stronger coffee talk with what I describe as strong black coffee. Again, some improvement. And then a more significant complaint arose. And the Citizenship Committee addressed this. And the Citizenship Committee was empowered in my institution to mandate a CPEP course. And so that physician went away at his own expense to spend 2 days with a boundaries course and a behavior and communication course. And again, we saw some improvement, but it was relatively short-lived. With the next significant complaint that arose, there was an automatic referral to the Medical Executive Committee. And the Medical Executive Committee recommended a mandatory extensive in counseling at Acumen, as a matter of fact. And that took hold. That physician came back, and I wouldn't say that he was 100% better, but he was markedly improved to the point where people made comments about it. He improved, but had ongoing monitoring and a zero tolerance policy. There were a couple of much more minor incidents, and as we like to say, as far as substance abuse disorders are concerned, relapse is a part of recovery, and that's clearly the case with behavior issues. But overall, he was functional, he was happier, had happier partners, and his wife was happy. His kids were happy. Get the next slide. And that lasted 28 months. And that's where I kind of go back to that whole idea that this is a prize fight. This was a physician who was well loved by his patients, who provided superb care, but in the end was unable to behave in a manner that was consistent with somebody that we wanted to keep on our medical staff, and his medical staff privileges were eventually withdrawn. And that's again a challenge. And so the only real lesson that we learned was the consistency was absolutely crucial in getting the help he needed, but we also had to allow him to fail on his own instead of us continuing to push things that really weren't going to be helpful in the long run. So, all right, and I think that's
Great.
That's what we've got today.
Lisa, it looks like we do have some questions. We'll turn it back to you, Lisa, and maybe we can try and address at least a few of the questions before we close.
Okay, thank you. All right, the first one. Can we mandate anger management course if the disruptive behavior pattern has persisted in spite of a few coffee conversations?
Absolutely. Again, it's following your policies and guidelines. But absolutely, if your CMO is empowered to do so, or if your medical executive committee or citizenship committee are empowered to do so, absolutely. And that's the whole idea, is to address it strongly if the informal conversations are not helpful.
Yeah, and Lisa, I think it's important to remember what options are available in terms of suspension, revocation of privileges, limiting of privileges, and you need to leverage those things. And if you remember, if you take action to limit or restrict privileges or suspend, all those things are reportable to the National Practitioner Data Bank. It doesn't have to be because of a clinical concern. A disruptive behavioral concern can generate disciplinary action and a report to the NPDB just as well. And those should be leverage points for you to get a physician to say, okay, I'll go to Acumen or CPHP or PACE, or I'll meet with leadership and talk about why my behavior is being disruptive. So you do have to sometimes force the issue. It would be wonderful if every physician that we talked to said, I had no idea I was being perceived that way. I will be better, I promise. But let's face it, that doesn't happen all the time. So.
Okay, thank you. The questions are pouring in. So, as a general rule, if known, is disruptive physician behavior to both staff and patients reportable to the state medical boards? If disruptive behavior is reported to the boards by support staff, is it generally investigated by state medical boards?
So I'm currently president of the Colorado Medical Board, so I think I can address this question. Remember that your medical board, licensing boards are complaint driven. So we only investigate physician performance, behavior, clinical issues if there is a complaint. If there's no complaint, then, by the way, the complaint can be anonymous. So we only investigate those issues. The only other way for it to come before the board is if there is a report to the National Practitioner Data Bank that an action has been taken against your license, against your privileges. And most states' licensure application says you have to notify the board if you're suspended, your privileges are limited or restricted, or your privileges are revoked. So yes, it should be reported to the licensing board, but only if specific actions are taken. If you have a collegial cup of coffee with somebody, they go to a course, they learn to be better, and they do better, that's neither reportable to the board or to MDReview.
Okay, thank you. Have you utilized programs that you would recommend for a practitioner that needs help to recognize disruptive behavior and can get help outside of the hospital setting, away from his or her peers?
Again, absolutely. The CPEP and the PACE program and each individual state's PHP programs are all outside the hospital. And the options available to physicians in those circumstances sort of depend upon what the problem is. Most PHP programs will allow a physician to call anonymously and say, I'm stressed, I'm not behaving well, I need help. And that's one avenue for being evaluated, sometimes getting counseling, sometimes getting psychiatric care, all depending upon the situation. So the answer is yes, and the options available are wide and varied. They just simply need to be, sometimes the physicians need to be directed in that manner to avoid going down the road of medical board complaints, national practitioner data bank, those sorts of things.
Okay, thank you. What has been your approach when the physician is not coachable?
Never heard it happen. Have you,
No,
Brock?
not once. Honestly, that really gets to the point of documentation, because if, in the long run, regardless of whether or not it's a physician with an affiliation with a hospital and privileges or an employment situation, which is becoming much more common,
Yeah.
the documentation piece is so crucial to make sure that at every step along the way that your own institutional policies have been followed. And sometimes the only option is separation. And it may not be a separation for poor care. And oftentimes it's not. That can be the ultimate wake-up call for a physician. It may not be, but not every person is coachable. There's no question of that.
Okay.
And Lisa, before you go to the next question, I wanted to highlight something that Jeanette Anderson sent in under the Q&A regarding retaliation. And she said, if you don't mind, Jeanette, I'm going to quote you because it's very valuable when it comes to retaliation. She said, when we've sent follow-up letters to providers about a conversation about disruptive behavior, which, by the way, is a great thing to do, put in writing. Look, we talked to you about the fact that you're having some issues with behavior, and here's what we talked about, but that you also include this sentence, and it says, the medical staff office procedure specifies that any retaliatory action are themselves unprofessional behavior. Even efforts just to identify who it might be could be considered retaliatory, and you are advised not to take any such actions. Great thing to include in your communication with the provider, because it sets the stage immediately for the fact that we're going to talk, this is about you. It's not about who reported you. It's not about anybody else involved. It's about you and your behavior, and that's where it needs to stop. So thank you, Jeanette. That's a great addition. Yeah, I think we have time for a couple more questions, Lisa, before we close.
Okay. Have you had to deal with physicians who are members of a physician union?
I have not. Don,
That's, I think you've stumped the panel. I'm not sure that I'm aware of.
Yeah, to a degree, though, the whole idea is similar as far as employed physicians.
Yeah.
What the union contract states has to include all of the same code of conduct, lack of retaliation, all those sorts of things. And so in the negotiation process with the union specifically, all that can be done actually through the union instead of individually with physicians.
Okay, let's see. The next three talk about the citizenship committee. When using a citizenship professionalism committee, do you use those committee members for the coffee cup conversations or just for the next level interventions? And then how do you select the citizenship committee?
So I don't know how yours is set up, Don. We do use those physicians as the coffee cup. That's the first intervention. So what occurs is the complaint comes in and the members of the committee give it a rating, and one person is assigned to evaluate that physician and talk to them, have that conversation, and come back to the committee to have a discussion. And then what occurs after that sort of depends upon how that discussion went. What we have tried to do is to get a larger cross-section of younger physicians on our committee. Not the ones directly out of residency, but the folks who've kind of gotten their feet wet, gotten a little established, are people that have been recognized as being pretty calm and collegial because they come off better when those interventions occur. They feel comfortable. The old wizened folks like myself are there oftentimes as the kind of, again, that institutional knowledge. We did in my institution when the citizenship committee was first formed, put some trouble physicians on the committee, and that was a disaster. So I would avoid that tactic at all costs.
Yeah, great points, Brock. All I would say is when you're approaching a provider who's having issues with collegiality and behavior and disruption for the first time, it's good to give a little bit of thought to whom is he or she going to listen to best. Is it a colleague? Is it a department chair? Is it somebody who is in the similar practice? Because that's your best opportunity to make a difference. As in terms of makeup of a behavior committee and professionalism committee, you want people who lead by example, because they know what it's about. And just by the fact that most of those people will have a reputation. Everybody gets along with Dr. So-and-so because they're collegial, they're receptive, they're open, they take what they do seriously, but not themselves so seriously. So those are my two thoughts to what Brock already said.
Honestly, this type of a committee really touches every part of the hospital.
Yeah.
And it's another place to have a breeding ground for those future medical staff leaders.
Okay. We are over, but we have one more question. And then hopefully maybe we can take the rest of the questions and maybe have you answer them and have those go out to everyone. How do you recommend utilizing FPPE to monitor adherence to the performance improvement plans related to behavior?
These are really good questions. So FPPE is as you all know, is a more focused, specific review, and it should be ongoing and it should be contemporaneous. So in circumstances like that, I think what's been helpful in my experience is to identify a proctor or a monitor or somebody who can, in many circumstances, be shoulder to shoulder with that provider. I mentioned previously our malpractice company, Copic, has a physician. His name is Dr. Dennis Boyle. I'm actually a good friend, and he's remarkable in his ability to just sort of stand by the side, watch an interaction, critique it, and identify opportunities for improvement in how that provider interacts with patients, with colleagues, with nurses. And if it comes to the point where an FPPE is required, I think you're going to need to identify a team leader, a monitor, a proctor, somebody who can be sort of hands-on in that continuous feedback loop to try and get that physician the help that they need.
Okay. Thank you. Thank you very much. Like I said, the questions are still pouring in. I'm trying to gather them all. I thank everyone for joining us. We had lots of attendees. I will remind you that you will receive an email from the Hardenbergh group by Friday. It will have our certificate and the slides. Please answer the questionnaire that is on it. I thank both of you for presenting tons and tons of information. And I wish everyone a happy holiday season. Thank you.
Thank you.
Thanks, everybody.